Welcome to Fluorescene.
So hello, and welcome to Fluorescene show number 10. I'm your host, Dr. Alan Glazier, and this week in ODs on Facebook, a doc posts a feel-good story of the week, a 16-year-old second opinion with chief complaints of headaches for the past 4 to 5 years, worsening the past 6 months, accompanied by blur, auras, and nausea. Very debilitating, especially during the pandemic. MRIs were negative. He was cleared by neuro and ophthalmology prior to his visit. The exam revealed mostly normal findings except a large intermittent exotropia with poor accommodative function. So the optometrist refers the adolescent to a local VT practice, optometric referrals, and 8 months later, he gets this note and was moved to tears, although he says it was only dust in his eye. Yeah, right. Lots of positive vibes, pride, virtual hugs were exchanged, and feel-good comments ensued, such as primary care optometry, who refer to VT makes such a huge impact, which is true, and great job. You're truly changing lives. A doc reminded the community, let this also be an inspiration to us to write thank you letters to those who've inspired us or had an impact on us. Any handwritten note brings lots of dust to everyone's eyes. And this is my favorite type of optometry, changing the trajectory of this young person's life. What could be better than that? May we optometrists never lose sight of our unique responsibilities to catch binocular and visual efficiency disorders, because no one else will. Next up, a doc shared one of his favorite parts of his profession, as he says, getting to see his patients grow up. He states, it's such an awesome part of our job, and the post was notable as it's so rare to have a photo comparison. A doc commented, look how much her hair color changed. Someone brought up the fact that they were now seeing the kids of the kids that they saw when they started, and another mentioned, so lucky that she, her parents, didn't drop you like a hot potato for an insurance change and $5 more out of pocket for someone further away, right? That happens. A doc posts that his optician has sold over 15 pairs of glasses to the same patient this year and asked what gifts members recommend to show his appreciation. So members mentioned things like gift cards, free pairs, gift baskets, handwritten thank you notes, and then there were members who said that they had patients who hadn't even come in for their exam in 15 years, much less buy 15 pairs. The winner was, you could send him my office address. A member posted about a girl who inherited 2 genetic mutations, which resulted in exceptional beauty. This young lady's name is Amina Ependeva, and she's diagnosed with 2 rare genetic conditions, albinism and heterochromia. Absolutely stunning. Docs commented they weren't sure how she can be an albino and have enough pigment to have a brown eye, to which another doc responded, cases of unilateral ocular albinism have been reported before, and there's a name for it. It's called Hermansky-Pudlak syndrome. This is where unilateral ocular albinism occurs along with systemic manifestations. One doc imagined her as Khaleesi's daughter from Game of Thrones. Where are the baby dragons, she asked. Fascinating case and such a striking appearance. Now I'm going to talk about snakes. Why snakes? Well, you know, on the list of the scariest things on Earth, snakes are right between tsunamis and global warming. So of course, people make them their pets. A doc posted about how a patient pet snake apparently got spooked one night and clipped his owner with the snake's lower fang, puncturing the nasal cornea. That is nasty stuff. The patient was eager to mention that it was a non-venomous snake, like that it made it any better. And look, I commend the hillbilly Bear Grylls here for even holding a snake, but what's the point of having a non-venomous snake if he's just going to blind you anyway? That's like getting a prenuptial with a Kardashian. Sounds like a safe plan, but when push comes to shove, it's really going to help you? No. Doc said, to be fair, I've seen many awful dog and cat and bird injuries to the eye far more often than snakes. And a doc added, that is why they're called nope ropes or danger noodles. And this post revealed reason number 899,000 not to own a snake. A doc asks, what are the best optometry jokes? Many were the ones we've all heard, like the optometrist who fell into a lens grinder and made a spectacle of himself. Hello. Or the cornea and cornea jokes. But some I never heard before that made me chuckle, like the doc who said the real joke was the checks that we received from Managed Vision Care, no doubt. And then the doc who added, what did the left eye say to the right eye? Just between you and me, something smells between us. Then a doc added, can't find the milk, it's just pasteurized. Get it? Just pasteurized? That's, sorry, my kind of stupid humor. And an optometrist says, an optometrist do it with ease. Then there was the kid that fell down into a deep well. He didn't see that well. Then the doc who told her patient that his problem was uncorrected hyperopia. He was so surprised and didn't know how to respond. He was nonplussed. And a doc added, there's the one about the new immigrant who went back home to his family praising American hospitality because at his first baseball game just before it started, he sat up in the highest seat in the stadium and suddenly everyone turned toward him and sang, Jose, can you see? Then there was the old Rodney Dangerfield joke of the patient who said to his optometrist, first thing in the morning, whenever I stare in the mirror for too long, doc, I throw up my guts. And the optometrist said, well, your eyes are fine. Then there's the joke, why did the exotrope say his wife was divorcing him? She was mad because she found he was seeing another woman on the side. Then there was the judge who asked a couple of lenses, how do you plead? They replied, not guilty, on the basis that we were framed. And last but not least, a doc wrote, one of my patients was pulled over by a police officer. While looking at her and her license, he says, hey lady, you're supposed to be wearing corrective lenses. She says, but officer, I have contacts. Officer says, I don't care who you know. You still have to wear corrective lenses. A doc posts, is it just me or do others get irritated when they're out trying to relax and somebody finds out you're an eye doc and then they start peppering you with questions? You know, docs could relate. I know you can. A doc posts, absolutely. I'm on vacation, and we met some people the other day when, to my disappointment, my husband mentioned I was an eye doc, and then, of course, I ended up doing a cataract lens implant consultation. Just what you want to do on vacation, SMDH. A doc added, it's so funny. It's basically the same conversation questions every time, and it goes like this. What do? I'm an optometrist. Oh, I wear contacts. I'm legally blind. My mom has macular degeneration or whatever, but had surgery, and now she sees great without glasses. Why are my eyes always red? I wear those 3-month contacts, but I always forget to change them. Is it true if you wear glasses, your eyes get addicted to them? Yada, yada, yada. Seriously, though, what do we expect? Everyone has eyes, and everyone has questions about their eyes, and that's how we make our money. A doc added, just keep a bunch of business cards on hand. Hey, why don't you come into the office sometime and we can go over everything? Then there's the classic, what do you think about that LASIK surgery? Ugh, hate that one. A doc helps out by sharing their strategy. I tell people I'm a stay-at-home dog mom and live off my dead husband's estate. Another doc strategy, I install pivots. You know, the little things in the road that go pit it when you drive over them. Stops people dead cold. But in my opinion, the one doc that had the best strategy says something that just totally turns them off from a continued conversation on any topic. A doc said, I just don't let people know if I'm on a flight and people ask what I do for a living. I tell them I sell life insurance. That usually shuts them up for good. Our colleagues and ODs on Facebook are pretty bummed about this when it happens, but I think we got to take the glasses half full view. Get it? Glasses half full view on this. There's a demand for optometrists. We're popular. Take that, you high school bullies. Who's the four-eyed nerd now, Kevin? We've got another great show for you today. We welcome refractive surgery thought leader, Dr. Marc Bloomenstein, a.k.a. the optometric comedian. We have a fantastic new segment brought to you by Dr. James Fanelli, organizers of CE in Italy and Europe conferences, called CE in Italy and Europe, the Tuscan Discussion. In this edition, Dr. Fanelli discusses diagnosing and treating chlamydial inclusion conjunctivitis and tricks and tips for discussing the diagnosis with parents of adolescents and more. Please hit that subscribe and like button to get notified of future shows and segments. And now, sit back, enjoy this week's Fluorescene show. So I'm here tonight with Dr. Marc Bloomenstein. Dr. Bloomenstein is a 1990 graduate of UCLA.
He received his optometric degree from the New England College of Optometry in 1994, just 1 year after the greatest class of all time graduated in Echo. His timing is, well, he's got other things going for him. But after graduation, Dr. Bloomenstein finished a residency in secondary ophthalmic care at the Barnett Dulaney Eye Center in Phoenix, Arizona. He's a fellow of the American Academy of Optometry and a founding member of the Optometric Council on Refractive Technology, serving as president from 2009 to 11. Currently, Dr. Bloomenstein practices at the Schwartz Laser Eye Center and is president of MRB Eye Consultants. He's delivered over 500 invited lectures worldwide and serves as a consultant to numerous industry-leading pharmaceutical, biomedical, and information technology companies. Aside from lecturing and publishing on numerous anterior segment and refractive topics, Dr. Bloomenstein is on the editorial board of Primary Care Optometry, Review of Optometry, Optometry Times, Advanced Ocular Care, Optometric Management, and Contemporary Optometry. He serves on the board of many optometric societies, including the Ocular Surface Society of Optometry and the OCCRS. He served as the president of the Arizona Optometric Association. Dr. Bloomenstein has been awarded the Arizona Optometric Association's Presidential Award twice. Dr. Bloomenstein also served as president of the board of the Arizona Charitable Foundation. Now, give me a second to catch my breath. That's quite a CV you got there, my friend.
Well, I kind of thought that, the longer my CV was, it's like you get paid by the word or the minute. So yeah, I was looking for stuff.
Yeah, well, you're getting paid.
Alan, did you ever get one of those things where they say you've been nominated to be like top optometrist or best optometrist?
Yeah.
So I have about, yeah.
Go ahead. Sorry.
No, I have like 11 of those.
And one of those
I was going to include those.
There's beautiful wood plaques that they send you, and you pay for it?
Yeah, pretty much. I remember the very first time, it had to be, like the early 2000s. I'm like, this is amazing. I cannot believe it's like, I want to thank anybody. And then when I got it again, and then when I went into somebody's office who I had no respect for and I saw it on their wall, yeah, I realized that it just didn't mean anything. So
yeah, some guy's running some company somewhere, some guy with a big, thick mustache that looks like the My Pillow guy making a ton of money giving those awards away, huh?
100%. That's actually a good idea. We got to do something like that.
Yeah.
Maybe what you could do is the Fluorescene Award, or the fluorescence or something, where you can just offer that to people. So we'll see.
Yeah, I'll put that on my list of things to do. How's that?
Yeah. You have no time. So
no time,
you have like tons of time. So.
Right. You'll be the. I'll hand all the work off to you. Now. What I did want to say, though, is you're here because a poll that I posted in Odie's on Facebook asking them who they most wanted to hear from, and you were one of the most requested interviews. So that's a huge compliment. I mean, it's big community. They know who they like, and they miss attending your lectures, which not only cover an incredible breadth of anterior segment refractive surgery and other knowledge, but they keep the docs on their toes waiting to hear what you say next. So what I would like to do, I like my interviews to be a little more personal, is have you start off by telling viewers how you've been hanging during COVID, what's been going on with you, and more importantly, did you get to go to Starbucks at all?
Thank you for asking. I did get a chance to go to the Starbucks. So many people don't know this, but I pretty much wish that I was a barista. It's like I aspire to be a barista, just being able to know what goes in a caramel macchiato versus what goes in a pink drink, or literally anything that they're doing there. I just don't think I can handle that. But every morning, so literally every single morning, I wake up and I ride my bike about 7 miles to the Starbucks, so there and back. And so when I come to work every day, there's the coffee cup looks like it made it through like a hurricane or something. It's spilled all over the place. People are like, "What is wrong with you?" And I'm like, "Yeah." So yeah, I did make it to the Starbucks.
How long did it take you?
Gosh.
How long did it take you to figure out not to put the opening where you drink through on the same line with the seam? That's what I want to know.
That is so. For those of you who are listening, if you didn't learn anything, that's exactly right. So you can see the seam here, and the opening is right there. Alan, you nailed it.
Yeah,
probably about 6 ties, that were ruined because it kept dripping on it. So yeah, many many months, many years. Yeah.
It's
So
one it's
yeah,
it's
kids
one of
today.
those problems that putting a cup in a cup doesn't even solve, you know. But
You're 100% right.
anyhow, been there,
So
done that.
you asked me what I've been doing about the vid. To be quite honest with you, it's Arizona. We're like, let's throw vid to the wind. You know, we're one of the states where our basically said the best to get rid of it is to give it to everybody. So then we're all in this together. So we haven't been really shut down as much as most people, but people, you know, most people who know me probably realize that I kind of have this ability to kind of project this like, hey, I'm super, but I'm no. I'm like, yeah, stay away from me. So I'm pretty happy because, like, you know, I love the fact that we wear masks now because literally it's like I don't have to talk to patients as much. So then, like, also too, you know, walking through public, it's like I have my sunglasses on, my mask on. I look like, you know, like a Unabomber, and I'm cool with that. And so it really just kind of keeps people away from me.
The look
But
suits
what have
you.
I been doing? Yeah, I've been hitting the Peloton. There's Peloton back there somewhere. I grew this out
Hmm.
for no reason because I have nothing like you going on up here. So
Uh-huh.
yeah.
It's all about that. You know, that optometric comedian title should be optometric Unabomber because you really are. You really look like you're turning into him.
You know, to be honest with you, I think that that should be my new title. It should just be Unibrow Bomber. So I could do it
Unibrow
later that.
bomber. Interesting. All
The
right. Well, we'll see.
Unabomber. The
You know, when I have
Unibomber.
you back, we'll we'll
Yeah.
we'll, we'll change it. We'll put the more accurate title up there.
Well, I have a feeling, Alan, after this airs, your ODs on Facebook community will basically say, yeah, we totally blew it on that one. We should have gone with somebody else. So I'm pretty sure that's going to happen.
Yeah, that's right.
Yeah.
I'll put a follow-up poll. You won't want to read that one.
Yeah.
Now,
Yeah, totally.
one of the things we didn't talk about in the bio because I didn't have enough air in my lungs was the collaborative corner, your collaborative corner show, which was on iTube OD, but now it's on iTube, right? Correct?
Yeah,
Yeah.
yeah. And I think it's yeah, I think it is on that. It's
Now,
through those kids.
I watched a few of them, you know, so I could have something to talk to you about today. And
Sorry
about
about that.
about a month ago, you talk about presbyopia, and you
Hmm.
said, this is a quote, all of a sudden, I'm reading this, I'm having a hard time seeing up
Hmm.
close. Now, I hate to burst your bubble, but we were a year apart in school, so I know how old you
Hmm.
are, and trust me, viewers, it ain't all of a sudden. Now, am I seeing you, though, with less glasses on lately? Like since September
So
2020, inquiring minds want to know.
so here's the deal with the glasses. So I'm a little bit nearsighted. I'm like about a minus 75, minus 50 in one eye, and maybe like minus 50, minus 50. So I've got about a diopter. And so I'm working that thing as hard as I possibly can.
All right.
When we first started going virtual, and you know, I would have my glasses on, the ring lights and stuff would come off my glasses. So people
Yeah,
are like, dude, your glasses are hideous,
yeah.
or take off your glasses. And but then also because I don't really have to read or do anything here, so I just don't wear them as much. But yeah, no, for I can still get by without it.
Yeah, there's
So I'm gonna ride that as long as possible,
well, there's a good
which is
optometric.
why working
Go ahead.
well, I was going to say, working in a cataract and refractive surgery center, people are like, oh, you've probably had LASIK. And I'm like, yeah, I have. It's amazing.
Well,
But I
there
really haven't.
there
But
have
they don't
been
have to know that.
there. By the way, a great invention. We got to figure out a way to get rid of those Zoom eyeglass rings somehow. But anyhow, there have been a lot of advancements in treatments in surgery for presbyopia. So this is a great segue into
Yeah.
talking about that. One of the hottest topics now are these small aperture presbyopia drops.
Yeah.
Tell us a little bit about them, and tell us what's the prescriptive range that patients qualify for with that technology.
Well, the interesting thing is, I mean, none of them are approved. And so it's interesting you say you bring that up, Alan, because what I've started doing now is talking to my early presbyopic patients, or basically, literally, I'll give you a perfect example. Earlier today, I had a detective from the Phoenix Police Department. And she was dropping F-bombs on me like they were going out of style. And I'm like, girl, I get you. Okay. And she also scared me because I kind of felt at any second she was going to throw me to the ground and cuff me, but that's a whole separate story. And so she was literally had LASIK about 4 weeks ago, and she's 49 years old. And her complaint now is I can see like the beep, beep. I don't know if this is an R-rated show, like if we can drop F-bombs. I'm not going to, but she did.
Okay.
I mean, but that's cool. So she's like, what the fuck? And I'm just like, hey, girl, I got you. But she said she can't read. So she was a perfect patient where I said, look, in about a year, I mean, maybe a little less than a year, because there's a company that's coming out where they're going to be using compounding. It's called, the name of the drop is called iFocus. And they're compounding one of these small aperture medications. And, compounding to me has always been a little risky. It doesn't go through the same FDA process. We see that with some of the cyclosporins or some of the other injectables. But Allergan's coming out with a small aperture pilocarpine. They're going to add a little special sauce in that. And they're in their phase 3 clinical trials right now. And you ask what kind of range that's going to be. To be quite honest with you, I think what they're looking at is whether it be mesopic or even just, in photopic environments, patients are going to be able to gain 3-4 lines of acuity, which I think is fantastic. So I don't think it really matters what their visual acuity is per se because of the pinhole effect they're going to get. And so I looked at this detective and I just said, hey, hang in there. There's going to be a drop that you won't have to use contacts for or glasses. And I think she's pretty excited about that. So, yeah, I mean,
we learn about the side effects of miotics, and for up until this point, it's been a big no-no because of the side effects. How are companies getting around this if they're using this, they're increasing the depth of focus this way?
Well, when I mentioned to you about the special sauce, right? So literally what they're doing is they're able to kind of create a meiosis without creating the miotic effect. They're not using anything to change the ciliary body effect. So they're not going to get the headaches. We're not going to get some of the ancillary effects that you're talking about, as well as the redness. Adding in something like brimonidine. I know there's another company that's using brimonidine to stabilize some of the side effects that you're seeing too. So I think what's exciting is that it's for those of us that remember like carbachol and pilocarpine and the effects that came with it. The newer versions of these are kind of almost what it reminds me of. It reminds me a little bit of like when Lotemax first came out, or loteprednol. And loteprednol was, we talked about the steroid side effects, and we talked about how we worry about increased pressure and cataracts, and knowing that it's an ester-based steroid. And right now, I mean, I know this is tangential, but we've got as much time as we can take, is that there's so many different loteprednol kind of like variants out there, whether it be, the new drop Isuvis from Cala and Inveltus from Cala, just different concentrations of the same amplified version of the loteprednol, or whether it be Lotemax SM, that submicron. And as a side note, did you know that they were originally going to call, Bausch & Lomb was going to market this as Lotemax AF. So it was not supposed to be SM, it was going to be AF.
Oh boy.
And so they went home and people are like, Lotemax AF. I'm like, hell yeah. I would write that drop all day long. And one of the, I guess the marketing people's kids said, ha, AF. That's funny. They're like, what do you mean? They're like, as fuck. And it's like, oh. So then they changed it to SM. But like that, remember how when it first came out, it was all very kind of soft steroid. It broke down by the esterases as opposed to the ketone-based steroids. So I think what we're going to see, especially with these new formulations of drops, especially the small aperture presbyopic drops, is that they're going to carry the miotic effect and maybe just a tiny little pseudo accommodation depending on what they add in there. But they're able to relax some of those side effects. So I think it's going to be pretty exciting, especially for us as optometrists.
We'll wait for the second generation, the loteprednol WTF. That's follows
Seriously.
AF, right? Well, you know,
Yes.
you had me at esterification because my next question gets into the molecular side of things. When I and I'm sure many of us, when we heard about this, I wasn't even thinking miotic. I was thinking that these are presbyopia reversal drops, you know, biochemical drops. And
Mm-hmm.
in the pharmacological treatment of presbyopia, I know that Novartis and other companies are working on drops that actually cleave the disulfide bonds that form in the lens. And my understanding is historically the problem has been cleaving bonds. It's been there, you know, there's a bunch of proteins we know that do this, but the problem has been drug delivery because you know, a drug that cleaves a disulfide bond in the lens will cleave every disulfide bond as it goes towards the lens if it's in drop form. And there are disulfide bonds in the cornea, the scleral, the retina. And I think that disulfide bonds are broken in the folding and unfolding of rhodopsin as well. So, you know, you can't put a needle in the lens to deliver it. So I'm sorry to go all biochem on you, but you know, how are they
Seriously.
approaching the drug delivery problem with those next generation presbyopia drops?
Damn, I thought this was going to be super chill. I think most of the people watching this are going to be like, honey, can you pull out the chemistry book? We need to get our OChem here, talking
This
disulfides and
this is as hard.
oxidation and
It's as hardball as it gets, but don't worry, no more. But this is really relevant, I think, because they're talking about these things, and I feel like a lot of the companies are presenting them as presbyopia reversal drops. Really, are we going to see that?
yeah. So before I answered that though, I was going to say when we first came on, I told you that I thought you looked like Joe Rogan. Now I've never watched his show, but I would just assume that he talks about like, you know, pooping and farting a lot and just other kinds of stuff. I'm not sure that he gets deep into oxidation and disulfide bonds, but hey, I feel ya.
He's
Yeah.
pretty
So
substantive in some ways, but yeah.
is he? Yeah, I've never watched him.
Yeah, but
Yeah.
he does
Dioptin.
the show high, so that's the big difference between us.
Is it though? Is it though, Alan?
I can't be
Is
talking
it?
about that.
So
Is not
he's
going to be.
high.
You
Yeah,
can't say that F
right.
word on here, and that's not a subject we're going to get into right
Right.
now.
Oxy. So anywho, yeah, so you mentioned the Novartis, and the Novartis is a prodrug. So I hope that what you just described is what they're hopefully finding because they've done some studies outside the United States, and more importantly, they're starting their phase 3 clinical trials for this prodrug, which basically means that it starts off in one form as it traverses through the cornea, and then it changes into that second form. So it's going to basically kind of create it won't be a disulfide bond breaker, if you will. I mean, the lipoic acid plus the chlorine esterase gets through the cornea, then it cleaves off the chlorine, and the lipoic acid then becomes the ability to kind of break those disulfide bonds as it gets into the lens. So they say. I think interesting enough, though, what you just said though is the proof is going to be in the pudding, I guess. You know, is it going to work? I don't know, because I think that's a lot more challenging than just creating that meiosis. Now we're talking, you know, softening the cornea, allowing more of the natural processes to reverse themselves. We'll see.
See, you do know your way around a molecule. You were yanking my chain there.
Yeah, you know, I mean, a little bit, but
No. Well,
I mean, interesting with the Novartis though. If you look at the data, I'm a little concerned because it only adds like 1 or 2 lines of near acuity, and I don't think that's enough.
Yeah.
I mean, patients want to have J1, J2, you know, be able to kind of feel like it's worth it. So I don't know. We'll see.
I think that, you know,
But
ophthalmology got all excited about the bendable IOLs over all these years, and all they did was provide 1.5 diopters. You know, where I think they're missing the ball on the bendable IOLs is they don't even take into account what optometry teaches with Sheard's criterion, that you really need, you know, 2/3 of the power that you're looking for in reserve. So if you're going to get a bendable 2.5 diopter lens, people will be able to see but won't be able to sustain that near vision. They're going to need 7 diopters, like, really, to provide. That's something I've always thought about. But anyhow, we're getting heady here.
But you know what I think would be even better is what if you combined the two of them? What if you did a like the dioptin, which is the Novartis drug. I don't remember the call letters that they're using, but I think they're naming it dioptin, with something like Presbyosol, which is the AbbVie, the Allergan drop. So you have a myotic pupil and you're working to try to maybe soften the lens. I wonder if that would, kick in and give patients even more.
Yeah.
So I wonder if they're going to be symbiotic.
Yeah, additive
We shall
effect.
see.
That would be, then I'd be set. I mean, my multifocal contacts work great, but like that would be incredible.
So I absolutely suck at fitting contact lenses. I've come to the realization that when a patient says that they're interested in contacts, I'm one of those people. I find a reason that they shouldn't have contacts, or I feign that I'm sick and I have to cancel the appointment. They need to schedule with somebody else. I'm terrible.
Hey,
Terrible
as long as that's not part of your job. I mean, you still as an optometrist are really the only doctor in the world that's qualified to fit contact lenses. They're not going to get a better fit than an ophthalmologist or an optician. So, I mean, they're still going to get the best thing they can from you. Although if you don't like it, that's a whole nother story. But
yeah, I don't know.
You're big on the other refractive thing. They come to you for much more serious surgical stuff like phakic IOLs, which I saw an article you wrote in 2001 where you called phakic IOLs the next great refractive surgery. And you know what I say about that?
Yeah.
Why aren't
Isn't that sad? But isn't that sad?
Yeah. Why aren't they?
So okay.
Do you like the sound effect? Did you like the sound effect?
Yeah, I love that.
Yeah.
It is crickets. And you know what I think too? I blame you, the listener, the optometrists out there, for not getting your patients psyched about this. Now, granted, there's only one company that makes one lens here in the United States that we have approved, and that's the Vision ICL. So in 1990, I want to say 1997, 1998, we were involved in the clinical trials for the hyperopic and the myopic version of the ICL. And we had 10 patients who were non-seeing hyperopic eyes. So literally it was a phase 2 study, right? We're putting it into patients, but the best acuity was 2200 or worse. And so it literally was just, can you do it or not? And we were putting in these lenses in these patients' eyes and they were freaking loving it. They were like plus 14s or plus 12s. I had a mortician who was in the study and she said to me, I will kill you if you take this lens out of my eye. And I'm like, and I think you know how. And then we started talking about like, do you do stuff with the bodies? And she's like, what's wrong with you? And I'm like, what's wrong with you? But it was phenomenal. The lenses worked great. We did the toric ICL myopic study in like 2000, 2001. And I really think that the FDA just freaking hated Star Surgical. So the Monrovia company, they basically just said, yeah, no, we don't give a shit about you. And I'm like, what the? So that lens finally was approved like so many years later. But I think the bigger challenge is, and this is why I said 2001, this lens sits at the nodal point. It improves patients' quality of vision from the inside out. It's reversible, not reversible. Let me digress. It's removable. Once you cut into the eye, you can't reverse that. It's a removable process. But the exciting thing about it is it's like wearing a contact all the time. And if something goes, not so great, you can just pull it out, poof, right back where you started. What I think.
Oh, go ahead. Sorry.
Oh, I'm preaching to the choir. But here's the thing: LASIK is like so freaking great that the question now has to be, well, why would we not do LASIK, and why would we do an invasive procedure like this? So. Yeah, I still think it's a great procedure.
See, I think you're blaming optometrists. I do too, by the way. I've seen some incredible cases, life-changing cases. I'm a huge fan. And it takes a really good surgeon to explant one of those things, though. So, but yeah, it can be done. And I see it differently. You know how you said you don't like to fit contacts, and maybe, people who don't do it lose some of their skills over time. Well, I think with the surface refractive surgeries, a lot of these surgeons who had grown up learning inside eyes from everything from 7mm incisions down in their training, now are just so used to being on the outside of the eye that they're scared to go in there. They don't want to take the risk of a crowded angle or, decreased endothelial cell counts. They're just chickening out, I think.
Yeah, I totally agree with you. I mean, I think, but this goes to my point, what I said before, is that why LASIK is an easy cop out, because if if a patient is a good candidate, and so one of the things that when I evaluate a patient for refractive surgery, I always say the same thing to them. I say, my job is to find a reason why you should not have surgery. You can have surgery probably anywhere, but you're not going to see great. We want to make sure that if we do this, that you're going to have the best opportunity to get the best quality of vision you can for the rest of the year, however long. And so I think a lot of surgeons look at that and they just think, I can do this with LASIK, or I can do this with epi-LASIK, the French version of PRK. Epi-LASIK, so nice. But then ICL just becomes, well, I will do that if those aren't available. And to your point, I think because it costs a little bit more and because it's more invasive, I think it's been pushed aside. But I also think what you said with the cricket sound, is that out of sight, out of mind. It's just, if doctors aren't seeing them, if we're not talking about them, then it just doesn't, come to light, which is why I think ODs, us, I have a lecture that I do. It's called Refractive and Cataract Surgery, Who Run Bartertown. Now, I try to get all these stupid titles because they amuse me and I'm the only person that I care about. And so do you know the reference to Bartertown?
No.
Okay. So one of the best Mad Max movies ever is Mad Max Thunderdome.
Okay.
Tina Turner,
I remember.
Right? Now, yeah, Mel Gibson, part of cancel culture. Maybe we need to let him go. I don't know. Still love Braveheart. Freedom. But Mel Gibson in that, if you remember the movie, 2 men enter, 1 man leave. 2 men enter, 1 man leave. But the whole town, Bartertown, was basically illuminated by a shit farmer. And his name was Master Blaster. And so literally, if you got sent down, like if you got in trouble at Bartertown, you would have to go down to this and shovel shit to just keep the pig shit, to keep the lights on. So Mel Gibson was down there and he basically was giving Master Blaster a hard time. And he looked at me, basically said to him, he goes, well, you're nothing. He goes, what do you mean I'm nothing? And he's like, I run Bartertown. And so he got on the big megaphone and he goes, and he said to Tina Turner, who run Bartertown? And he made her basically say, Master Blaster run Bartertown. How I'm going to circle this back to optometrists is we are Master Blaster. We run Bartertown. We see 90% of all contact lenses, as you said. We see 80% of all comprehensive eye exams. And to me, the power that we yield by telling our patients what surgeon they should see, what procedures may be in their best interest, what new technology, whether it be, you're talking multifocal contacts or the diffractive lenses or the EDOF lenses or the EDOV lenses that they can get for surgery, the optometrist really is the one who makes those decisions. And I think we have to empower ourselves. And I think sometimes we wait too long to do that. I think that discussion should be at every appointment and as early as we possibly can, what their options are. Start with contacts, then move to refractive surgery, then move to their cataract lens options. Who run Bartertown? We run Bartertown. We do.
Wow. That's some soapbox. Yeah. That's like a Costco-sized soapbox that you just got off.
Yeah. That is a long drink. That's a long walk for a short drink of water. But you know what? We run Bartertown. We do.
I love it. I love that analogy. That is great. I'm going to have to absorb that and maybe I don't know what I'm going to do with that. Wash myself off.
You might need to take an Imodium or something.
Take a shower after that one. One of the things I want to tell our viewers, one of the things I like to do with this show is to get people to know the people I interview, because they see them on the stage, they see them on the videos. These viewers are going to get to know, they know the lecturer, but they don't know what you've done for the profession. And you've served as legislative chair for the AOA, president for your state, and on the political action committee of the AOA. Can you tell our viewers how important supporting state and national association is to the profession, and how people who aren't involved should look into getting involved?
Yeah, it probably is the second most important thing you can do. I mean, the most important thing you can do, obviously, is keep yourself educated so that when you walk into a lane, you're not talking about something 10, 15 years ago and the rest of the profession is moved on, which is, at the start of this talk, we were talking about some new products that haven't even been approved. And it's just, to me, I think, it's more gratifying to be able to look at a patient and say, hey, I know something's coming, or hey, look, there's a new product. Some of these nouveau or kind of niche products, like for neurotrophic keratitis, something as tiny as like Oxervate from Dompe, which some of you viewers have used, and some of you may be going, I have no idea what he's talking about. The second thing to me is keeping involved in the profession. And the only way to really do that is by supporting the people that keep our profession where we're at. There's so many things that the AOA are doing behind the scenes, and your state association is doing, your legislative, it's interesting because if you look at 2021, right? And you're watching right now, we're in the middle of, what's going on in Washington, D.C. We saw what happened on January 6th in 2021, just how fragile a lot of these legislative decisions and the scope of our practice is hinged on legislation. And so supporting legislators that basically align themselves with our thought process, which is that we know that we're capable of managing and caring for patients from the front of the eye to the back of the eye. And the AOA basically is the only national source that actually can accommodate that for us on a national level, and your state association is the one that keeps it within the state. So, it's interesting you brought up, the things that I did early in my career, and I just don't even think about it, but I would never even think about not being a member of the AOA. Going to the AOA meetings, or listening and being involved in what's going on in legislation. So yeah, first and foremost, educate yourself. Second and foremost, stay involved. Absolutely critical.
Thanks for saying that. You influence a lot of people out there, and when that comes out of your mouth, it means a lot more than just anyone telling everyone. So I'm sure people will take that to heart. And we're getting close to wrapping up now. A couple things. You live in Arizona, and you're a workoutaholic. We've already talked about the biking thing, right? We were in Boston together, but could you have picked a hotter state to live in, like to drive anything except other than a Peloton?
Yeah, I probably could have, but I actually ended up in Arizona, not because I chose to end up here. So true story. I mean, I don't know about you, Alan. What did you know you wanted to be an optometrist since you were like you are tiny. So when you were even more tiny, like a mini Alan?
You mean when I had hair? Yeah. I did not know that. No, I wanted to be a vascular surgeon.
Really? So then what chose, I'm going to interview you now. So when did you decide to become an optometrist?
I took a year off after undergrad, and I was a little confused. I went and followed a few vascular surgeons, and they weren't making any living until they were 37 after all their training and their different residencies and blah, 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 right? Externships. And I'm like 37, right. I sound really old to me. My dad's an OD. He was an OD. And while I was at home, I never stopped to think about what he did. But that year I was watching him, and I'm like, he was just so happy with what he did. And it was medical enough for me. I would get out at 27. And so it just seemed like a better path for me. And it was. Yeah. It really was. But, I still have times where I think
worked out nice for you.
How many people's lives I could have saved. But now we're saving vision. So, it's all good.
So my path was very similar to yours. I was trying to date some girl in undergrad, and going biology at UCLA, and I'm thinking medical school, and I actually had a biochem teacher say to me that, with your personality, I don't think you should be a doctor. And I'm like, why? He goes, because you're not smart. And I mean, I don't know if that was a joke. I didn't, but So I was in this biochem class with their gal, and her name's Terry Vo, if I can say her name. She's actually an optometrist in Virginia. And I'm like, Terry, we should study this weekend. And Terry's all like, oh, I'm studying for something called the oats. And I'm like, yeah, so am I. No idea what the oats were. I have no idea. She goes, I didn't know you wanted to be an optometrist. And I'm like, yeah, for sure. I mean, this is the absolute 100% truth. I called up the oats, got somebody in Houston. She's like, you better hurry up. The test is like in a few weeks, y'all. And I'm like, maybe I'll go to Houston. And she goes, maybe you will. Where you at? And I'm like, I'm in Los Angeles. And then dude, can you hit your cricket sound again?
Oh. Sorry. I wanted to spare you that.
So I'm like, okay, crickets. And I go, hello. And she goes, oh, I was just thinking, yeah, you're probably better off staying in California because we only take the sharpest knives in the drawer out here in Houston. So I ended up taking the oats. Terry was not interested in me. And she was interested in Ramon, our TA. He was ripped. He was from Costa Rica. Can't
Hold
blame
on.
her.
I got a sound for that.
Okay.
Go ahead.
Yeah, pretty much. So I ended up actually going to school in Boston. And then I came out to Phoenix to do an internship, your fourth year internships things. And I mean, fell in love with the state. I mean, back in the early 90s, it was phenomenal. I mean, yeah, it was racist pretty much at that time still, but it was, it was great. I mean, great learning experience, great opportunities. And so I've never left. Yeah, good times.
I didn't think Boston was any less racist than anywhere I've ever been. I thought it was, that's a whole other conversation, but
wicked,
look,
wicked docking.
Two Necco schlubs that made good. It's great. Let's wrap up with, tell us about, I know your wife Jill is an optometrist and you have sons Zach and Maxwell. What are the kids doing?
So first of all, Jill is not an optometrist. She pretends she's an optometrist. Yeah. So she's actually, she's a speech. So there was a great story where I had her try to diagnose my EKC, brought her into the lane. She looked at my anterior chamber. She's like, yeah, I think I see cells. So she diagnosed neuritis. So to be quite honest with you, Alan, she's the worst optometrist that's not an optometrist I've ever had. It was EKC. She sucked. So no, she's a speech and language pathologist.
I thought I did my homework, man. I feel stupid now.
No, it's all cool. So
the internet
between
says
the two of us, we
differently.
have 4.
The internet says differently. I'll show you.
Yeah, you'll have to send that. Yeah, I mean, yeah. But between us, we have 4 kids. I have 3. She has 1. My oldest son is going to be a nurse. He's in Henderson, which is good. My third child is my daughter, Sierra. She's going to be a dentist. She's breaking my heart right now, because, as a UCLA graduate, she's at USC Dental School.
First world problem.
Disgusting. So, yeah, seriously. Jill's son is in the Navy. He's 21. And then my youngest son, Max, thinks he wants to be an optometrist. He's a second year at U of A. And he goes, I watch what you do, Dad. He goes, you don't work that hard. Looks pretty cool.
That's awesome.
Like, okay, Max. Yeah.
Well, listen, sounds like a beautiful family. My dad is as proud as he was that I followed in his footsteps. The fact that I didn't want to do VT broke his heart. I'm like, Dad, how much can I follow in your footsteps, for God's sakes?
Yeah.
It's all good. But well, listen, this has been a blast. It's always good catching up. I will get. I know that these live CEs are going to be happening before we know it. So I look forward to catching up with you at one of these conferences. You're going to be at the at what is it? What's happening in Orlando? Oh, Expo. You going to be heading down there?
Expo in May. Yeah, I'll be down there. Everybody should come on out.
I think it's in June. But anyway,
is it in June?
I think so. Well, we'll hang in there, and then
we'll be there.
Thanks again. This has been great. I want to hopefully you'll join us again, and in a few months we'll have you back.
Anytime. Let's do it anytime, Al.
All right, bud. Listen, take it easy, be safe, and keep rocking that clinic, okay?
Bye, everybody. Be safe.
Hello, I'm Dr. Alan Glazier, and welcome to Fluorescene News. This week in Eyecare research, researchers studied whether Manuka honey is a treatment for dry eye disease and how it might compare to conventional eye drops on tear film properties. Researchers concluded Manuka honey formulated eye drops were effective in reducing tear film evaporation rate and were more effective for improving symptoms of dry eye than when they were compared with the control eye drops after 28 days of treatment. In other dry eye news, Hovione has completed the phase 2 trial of Mezuvo, a minocycline repurposed for ophthalmic administration for the treatment of dry eye disease caused by meibomian gland dysfunction. The controlled study was conducted across 26 clinical sites in the U.S. and included 270 subjects suffering from dry eye associated with MGD. According to the company, the study observed a favorable clinical outcome in 70% of subjects. Less than 3% of subjects reported blurring vision or eye irritation, indicating that the product is safe and well tolerated. In contact lens news, the first trial evaluating MediPrint Ophthalmics LLT-BMT1, a drug-eluting contact lens being developed to treat glaucoma, has been successfully completed. LLT-BMT1 is a contact lens printed with betamoprost using MediPrint's proprietary process. The trial, the first in the company's Sustained Innovative Glaucoma and Hypertension Treatment, or SITE, clinical program, demonstrated that LLT-BMT1 has a favorable safety and tolerability profile. Additionally, the investigators observed an efficacy signal from a single dose, which the company stated encourages them to proceed swiftly with SITE-2, a phase 2B dose-ranging clinical study intended to optimize dosage for efficacy. The investigators reported that the treatment demonstrated 100% tolerability with no significant adverse events reported. In myopia news, the World Council of Optometry and CooperVision have announced a global partnership to raise awareness of myopia progression and encourage optometrists to embrace a standard of care to manage the condition. The joint initiative's standard of care definition and promotion will be centered around evidence-based approaches without bias towards any particular treatment methodologies. In other myopia news, researchers conducted a study analyzing the 2-year add-on impact of using low-concentration atropine in poor responders of orthokeratology in myopic children. As compared with ortho-K monotherapy, combining 0.01% nightly atropine did not significantly change the 3-year axial elongation outcome for fast myopia progressors and poor responders of ortho-K. In AMD news, the treatment burden for patients with neovascular age-related macular degeneration can be a stumbling block in treatment adherence because of the need for very frequent dosing to maintain vision. Adeno-associated virus gene therapy vector ADVM-022, also known as intravitreal gene therapy, has demonstrated the potential to reduce that burden substantially based on the phase 1 OPTIC trial results. The preclinical data from 2 studies of non-human primates showed that intravitreal gene therapy facilitated stable, long-term protein expression up to both 21 and 30 months after one injection. The results also showed evidence of a dose response, with patients receiving the high dose not needing supplemental injections, compared with patients who received the low dose. The potentially bright future for this intravitreal gene therapy in wet AMD may open the door for the treatment of diabetic macular edema as well. In retinal news, a study compared choroidal thicknesses in patients with and at risk for coronary artery disease and investigated whether thinning of the choroid can be used as a biomarker for development of coronary artery disease in patients at risk. The researchers concluded patients with coronary artery disease have a decreased choroidal thickness compared to patients at risk of coronary artery disease. Detection of choroidal thinning in a patient with diseases such as diabetes, hypertension, and/or hypercholesterolemia, which pose a risk for coronary artery disease, may be a predictor of development of coronary artery disease. In other retinal news, a Hong Kong scientist has developed a method to use machine learning and artificial intelligence to scan retinas of children as young as 6 to detect early autism or the risk of autism. The method uses a high-res camera with new computer software which analyzes a combination of factors, including the nerve fiber layer and blood vessels of the eye. 70 children were tested using the technology, 46 with autism, and a control group. The technology was able to identify the children with autism 95.7% of the time. The average age tested was 13, with the youngest being 6. And in more retinal news, scientists studied Aurora kinase B, which plays a pivotal role in the regulation of mitosis and is gaining prominence as a therapeutic target in cancers. The purpose of this study was to determine if Aurora kinase B plays a role in retinal blindness, how its expression is regulated, and whether it could be specifically targeted. They concluded that Aurora kinase B is overexpressed in retinal blindness, and targeting it could serve as a novel therapeutic strategy to restrict tumor cell growth. And that's all for today's Eyecare research news. Don't forget to subscribe to this channel for updates. Now, on with the show.
Ciao tutti, Jim Fanelli here from Wilmington, North Carolina, with another segment of CE in Italy and Europe's Tuscan discussion. Today's discussion is going to be a discussion of an interesting clinical scenario. We know how to treat this disease. The disease management actually is very simple and straightforward, but the clinical case itself can pose a conundrum for us in clinic in managing patient expectations as well as overall patient management. So let me lay the groundwork for you. You have a patient, let's say, who is a 17-year-old young individual, female, who presents to your office as a new patient with mom in tow for a chronic red eye. Now, this patient wears contact lenses. So we've all seen individuals where the contact lens is the root of the problem in a majority of cases. But this individual was seen by her primary care doctor. Why they go to their primary care doctor, I don't know. But the patient was seen by their primary care doctor and prescribed an antibiotic, which I'm not sure of what that antibiotic is. Needless to say, it didn't resolve, but ultimately the patient sought care from another provider. That provider put them on a different antibiotic, and in fact, that provider put them on a 4th generation fluoroquinolone. I would assume that that's a different antibiotic than the first provider put the patient on. But this drop also is not helping the individual. So this is more of a chronic recurring issue that mother is now seeking a second opinion. So mother is in tow, I'm examining the patient, and clearly this is a unilateral condition. The cornea actually is clear, the contact lenses are fitting reasonably well, but this has all the hallmark signs of chlamydial conjunctivitis, inclusion conjunctivitis. And that poses an interesting dilemma for us in clinic insofar as how we discuss this with the patient to see what kind of accurate history we can get and how we manage it, of course, with mom in the exam room as well. So herein lies the difficulty. I'm a male. I'm seeing a young female individual whom I very strongly suspect has inclusion conjunctivitis, which, as you well know, is a sexually transmitted disease. So how am I going to extract a history from this individual with mom sitting there? First of all, in the world in which we live, this can be seen as unwanted advances or unwanted queries into an individual's health history. But also, from a practical perspective, what's the likelihood of getting an accurate sexual history from a 17-year-old with mom sitting in the room? For the female doctors who are watching this video, I'm sure you have very similar situations present when you're dealing with male patients with chlamydia. So how do we make this happen? Well, first of all, it's very difficult to, with 125% certainty, determine that the patient does in fact have chlamydia. It has very characteristic signs. and symptoms, which we can see in the attached photo. And I'll get to that in a little bit more detail. But during the clinical visit, it's hard to be really certain that this is in fact chlamydia. The clinical indication and the clinical signs and symptoms look like chlamydia, and you're probably right that it is in fact chlamydia, but there's always that possibility that we might be wrong. So here's a couple of suggestions on how you might approach this particular individual. What I tend to do in situations like this is I have a conversation, an open conversation with mom and the patient, explaining to them that you have a recurring condition. That's why obviously you're here for me. This may involve the need for oral antibiotics, but let's do this. You've already been on 2 different antibiotics. Let's try another one. And what I'm doing here is I'm giving the situation the benefit of the doubt that this may in fact not be chlamydia. So I'm going to look at the existing medications that the patient was on, choose another medication that should be able to cover the bases. But if this is in fact chlamydia, that medication that I'm going to be prescribing simply is not going to work. So I will talk with the mom and the patient and say, we're going to try this particular medication. We're going to see how it performs, but I want to do a follow-up in about 5 to 7 days. Now, if this is in fact chlamydia, I know that when they come back in, we're not going to see clinical improvement. But what I will have my staff do when this patient comes back in, and more than likely mom will also be accompanying the patient, I will have my front end folks try to tie up the mom with an insurance question or some type of paperwork issues while I examine the patient. Now, I'll have a technician in the exam room with me at all times, but what I'm trying to do is to ascertain and get a good feel for if this is in fact chlamydial conjunctivitis. And when I'm seeing the patient, if I do in fact really feel that this patient is no better and it's looking more and more like chlamydial conjunctivitis, I'm going to have a conversation with the patient that goes something like this. Sally, we put you on an antibiotic. The other doctors have put you on antibiotics and they haven't worked. What you have appears to be chlamydial conjunctivitis, and this is a sexually transmitted disease. So I'm going to ask you some questions that might appear to be very personal, but I need to get the answers to these questions. At which time I will then ask the patient those questions with my technician present. Now, the likelihood of getting an accurate history at this point is probably going to be pretty higher because mom is not in the exam room. But once I've determined that the history matches, that this is in fact chlamydia, then I will say to the patient, when mom comes in the room, and she'll be in shortly, one of us is going to have that discussion with mom. I can do it, or you can do it, but one of us has to have that topic discussed with mom. So I'll put the onus on the patient, and everybody's going to be different. Some will say, you tell mom. Others will say, I want to tell mom. But if they want to tell mom, that's fine. But I need to be there while they're telling mom to make sure that we're all on the same page. You can do something similar to that with adult individuals, especially if their spouse is present. This creates a rather awkward clinical situation. And again, we're not 120% certain that this is in fact chlamydia until we've gone through a trial period with another antibiotic, and assuming that the clinical signs and symptoms match up with chlamydia. Everybody knows what chlamydia is. It's caused by the obligate intracellular bacterium Chlamydia trachomatis. This lives inside epithelial cells, and on GEMSA staining, these epithelial cells have inclusion cysts, thus the name inclusion conjunctivitis. But chlamydia is in fact a sexually transmitted disease, and what we're seeing in the eye is just the ocular manifestations of that disease. For individuals who have chlamydia, males may have urethritis and discharge. Females, especially if this is untreated, this can lead to chronic pelvic inflammatory disease, which can ultimately result in scarring of the fallopian tubes and make it difficult for that individual to become pregnant later on in life. So this does need to be managed in the individual as well as the patient's sexual partners. Management is pretty straightforward. We have a couple of different antibiotics that we can use. The most efficacious from a patient perspective of ease of use is simply to use 1 gram of azithromycin in one single dose. That could be 500 milligram capsules, 2 of them taken on the same day, a couple hours apart if it's going to upset the patient's tummy. You can use erythromycin. You can use doxycycline as well. But the treatment is relatively straightforward. Typically, I'll go to 1 gram of azithromycin, just one single dose, just from a compliance perspective. But again, the patient is going to have to discuss this with their sexual partners and have those individuals treated as well. What about resolution? What's resolution going to look like? Resolution is not going to come about in a matter of 3 or 4 days. It may take upwards of 2 to 3 weeks before the condition does become resolved. And that's why this has to be discussed with the patient and the patient's family to make sure that they understand that this is not going to be an instant gratification kind of resolution. Okay? So I hope that you got 1 or 2 clinical pearls from perhaps a discussion on how to deal with these individuals. Every case is different. Every case is going to involve some modification on your part insofar as how you manage the patient in the exam room. The clinical management of the disease, pretty straightforward. So with that, I'll sign off from Wilmington, North Carolina. Hope you have a great day and hope to see you at one of our programs on the CE in Italy and Europe tour in 2021, 2022, 2023. Lots of great locations upcoming. Hope to see you there. Ciao.